Today we're going to talk about the care coordination piece of emergency telehealth and care coordination and the goal of targeting frequent ED use and hospitalization. As we look at the issue, and this was what we discussed when we talked in the orientation, and that is emergency telehealth and care coordination is not just an ER. We have an opportunity because of the environment that we're in and the electronic connections that we have to the people that we're in to really do more than just look at the patients as they come in and see them just as if they were coming to an ER. And one of the key parts of that is being able to identify patients in need of care coordination. Who are the patients with frequent ER use? Who are the patients with frequent hospitalizations? The big picture of what are we doing here, and they use the example of an elderly patient with dementia curled up with full coat, and we kind of go, what are we doing here? What's the purpose of what we're engaged in? Take a look at that bigger picture, and ultimately look at a lot of frequent ED use is behavior, whether it's behavior on the part of the patient, behavior on the part of the staff at the facility, behavior on the part of their caretakers or family. Somebody's making a decision that says, I want to go to the ER. And it's kind of like, how are they making that decision? So we want to get into that process. Dr. Collins talked Friday about managing anxiety, that a lot of what we may end up doing is managing anxiety, and through that, managing their behavior. And ultimately, we'll talk more about the development of emergency department care plans. The overall goal of what we're trying to do with the telehealth is support the concept that the goal of the healthcare is to keep the patient in the best health at the lowest cost center. And the lowest cost center is the home or the facility that is their current home or wherever they're at. And this is really a concept in healthcare of moving the patient to the left. And what you look at is you look at each of the places where a patient can be, whether it's home, a facility, a correctional facility, nursing home, group home, whatever, their primary clinic, an urgent care clinic, an emergency department, to observation, to admission, to an ICU. The ICU is the highest cost, most intensive component of our healthcare system, whereas the home is on the other end. It's the least intensive and a place where we can manage patients. And so the whole goal is, as much as we can, drive this process to the left with the goal of keeping the patient in the best health. Let's do what's best for them, but do it at the lowest cost center. Some of the articles out there in terms of who are these people that we're targeting, who are the people that we're looking at, and what they found, and this is demographics from ER use within the VA, showed that 83% have no ED visits. They're never used it. And I know a lot of us from the standpoint asked this the last time we've been in an ER, and the answer is not for quite a while. And we don't hope to be there as we go about our business. The group that we're interested in is this group of kind of 1.5% of the patients which have 5 to 10 visits, 11 to 25 visits, and greater than 25 visits. These are the patients that we're trying to target, and it's about 1.5% of the population. So for every 1,000 patients that we may have in our healthcare population, 15 of those, right, will be frequent ED users. And so those are the patients that we want to look at in terms of how we manage. The other thing that I've kind of really become aware of as I've worked with emergency telemedicine and seen pretty much the rise of teledoc and the use of telehealth in that is that one of the risks in emergency telehealth is that it just becomes another item on the healthcare smorgasbord. It's something else that people want to consume. And there's people out there that are just, those 1.5% of frequent ED users, for whatever reason, are just out there waiting for another healthcare service to consume. And one of the theories is it because of unmet needs that they feel They, you know, my fill in your blank, primary doctor, correctional facility provider, nursing home provider is not providing me with the care that I need. And therefore I need to go to the emergency department and to the hospital where they've got all the technology and they can do all the diagnostic testing and they can do everything that I need. Is that why they're going? Some of it's behavioral. People just get into the mode of using the emergency department. And I think in this setting, in pediatrics more, the idea of proxy, where somebody's, you know, kind of sending them to the ER to satisfy their own needs or feelings that they might have about whether a patient needs to be seen. So the challenge here is to avoid just increasing healthcare utilization. This was a study that they did with Teladoc, and what they found was out of only 12% of the patients that were seen in Teladoc had decreased healthcare utilization in the year and a half following their Teladoc consultation. And 88% had increased healthcare utilization. And in most cases, the increase in healthcare utilization was the Teladoc consult. So it wasn't changing a thing. It wasn't making any difference in terms of their pattern of healthcare, their use of healthcare, or anything else. And in many cases, it was just becoming more. It was something that they were adding on that people could use, but they would still use their urgent care, still use their ER, still use their hospital, whatever, and manage it. So, and how, as we move forward, how can we measure that utilization? What are some of the reasons that people use it frequently? Homelessness, a medical diagnosis, whether it's a chronic medical condition, CHF, COPD, chronic renal insufficiency, substance abuse, which we're all familiar with in the ER. Different psych diagnoses, particularly major ones like schizophrenia, bipolar, and personality disorder, I think maybe is one of the other ones that people come in. What they found in these patients, that most of them received psychotropic or opioid prescriptions. We did the study of the frequent utilizers at ECMC and looked at the top 100 patients. Guess what frequency of those patients had Dilaudid ordered for them while they're in the emergency department? 100%. It was pretty close to almost every single one of those patients got Dilaudid. So, you know, or they're patients just with frequent use of outpatient mental health or medical facilities. The driver most strongly associated with schizophrenia, homelessness, opioid prescriptions, and heart failure as we look at those. And heart failure is one of the groups that we're going to be spending a lot of time working with and determining how we manage those. Just to give you an idea of the frequent ED users, you'll hear me say the word SFIDU every now and then, which is super frequent ED user, or mega frequent ED users, which is 20 or more visits. And unfortunately, we've got a good number of patients that fit into that category. And we've already, our first patient in our care coordination for People Inc. was a patient with who's a mega frequent ED user as it stands right now, as we're looking at him. The other concept that and this is from work that I did at the VA, where I looked at frequent ED users, and that was the concept of a rapid riser. And the best correlate of this is probably the 60-day summary that you get by looking at HealthyLink, where you can see all of their ED visits within 60 days, their hospitalizations within 60 days. Have they been to their primary doctor in the last 60 days? You know, what are some of the things that would, and in that setting, frequent ED use can be, you know, greater than 2 or 3 visits within 60 days can ultimately lead to super and mega frequent ED use if it continues at that rate. The other thing that's probably the most important thing to look at is that combination of frequent ED use and hospitalization. As I looked at, you know, I created a point system where I gave them 10 points for a hospitalization, 5 points for a recent ED visit, and then 2 points for a 6-month ED visit, and really tried to scale the patients based on that data of looking at who were my most frequent ED users, who were the ones that were increasing it to the greatest degree. Some thoughts that I came to as we're working on these patients is when you're working in the ED, a lot of these patients kind of get lost in the noise of the emergency department, the 45,000 you're seeing or the 18,000 at the VA. And, you know, we all kind of run into them at different times. The other piece of the ER that's almost a setup for frequent ED use is that there's 72 different or more providers that may be working with that patient at any time. So the odds are pretty good that a frequent ED user will come in and hit a different patient each time, unless you're JQ, which the likelihood is very high that you're going to hit every ED provider in the emergency department. And usually a groupthink develops about who these people are. The nurses oftentimes may know better because they're there on a regular basis, and they'll know who these people are. And really, unless they're nasty or threatening, we don't think anymore. We just let's get out of here, just taking care of them, get them out of here, and let's move on to the next patient that we've got. And they just become part of the landscape. And so one of the things that I started to look at, particularly at the VA, was let's take a closer look at this group. Let's find out what's going on with this group. And the beauty of the VA is that it's an integrated healthcare system. So all of the records, everything that we do is all in there. There's no additional costs for procedures. No specialists are sitting at the same table with ER as sitting at the same table with primary care and psychiatry. And it's really a concept of, okay, what's best for the patient in this? And it has a comprehensive electronic health record, so you can see every one of their interactions with the healthcare team just listed one after another after another. And we can bold the emergency department visits so we can see kind of where they're at. But you can see see notes by social work and care coordinators. You can see the primary care notes. You can see what's been done. And one of the most impressive things that I saw with this population is the effect of home-based primary care. We'd have a patient that was coming to the ER almost every other day and 2 times a week, and home-based primary care kicked in, and that patient's ED visits went down to 0. It was just like a wall, when home-based primary care kicked in. And that's really what mobile health is involved in, and one of the reasons why we're working with that, because it's an effective model for managing patients looking at them from the standpoint of a risk assessment. That's what we do in terms of how we manage it. And in the VA, the question was, how do you manage non-VA care? How do you coordinate non-VA and VA care in an integrated health system? And we've done a bunch of different meetings, multidisciplinary meetings, to look at these patients. And we had a couple of really frequent ED users, and we got together in a multidisciplinary group, and one person reviewed the record and found out that he had been doing the same behavior of crashing in the ER every night with his homelessness and his cocaine use and his intoxication. He'd done it in Buffalo, he did it in North Carolina, he did it in Florida. He just moved from one location to another doing the same behavior. Really identifying patients and getting together and coming up with a plan. At the same time in primary care, Brad Mercereau was working with opioid use and CHF use, or CHF patients in the primary care group, and coming up and developing panels to go through every patient in that setting. The current one they're working with is patients who have combined opioid and benzodiazepine use, and trying to highlight and identify those patients who are at risk. The other behavioral health folks at the VA is the MHICM groups, the Mental Health Intensive Care Management, which is really a group that's designed to focus on how do you manage a schizophrenic patient or a bipolar patient in the population, and manage them frequently and support them frequently and identify their issues so that you manage them as best you can in place and where they're at. And so that led to a group coming together of people to try to really address this issue. And one of the things we came up with in that process, and I called it the no-fly list, but it was basically a listing of all the frequent flyers in the ED, and all the way from the first most frequent to the least, and really looking at the process of getting data on who these people were, and being able to look back 6 months and 6 weeks and come up with an idea of who were the patients who were the most frequent ED users in the list at the VA. And one of the things that I found, and I've described it as a whack-a-mole game in terms of trying to manage these patients, because you can you can take individual patients, and the number one patient that we found when we first started looking at it was a schizophrenic patient with cocaine use, and he'd crash in the ER with homelessness, and say, you know, and basically what we found was the answer to managing him was a fiduciary. We needed to make sure that he was 50 to 100% service connected, so he had a great check coming in every month or week. And so by doing a fiduciary, we were able to manage this money flow and keep him from being the most popular guy at the party when he had the money to buy cocaine. And it was interesting when we saw it, his ED use dropped significantly. And importantly, now when he does come in, he's not intoxicated, he's not drunk, he's not, you know, he's still schizophrenic, and he's kind of interesting from the standpoint of talking to him, and he's got some minor problems, but not like before when he was crashing in the ER all the time. So again, look at all those patients. But the thing we found also in terms of looking at it was that we really weren't changing the whole group of frequent ED users. That number was remaining the same. And so that's why I say it's kind of a whack-a-mole game. As soon as we took care of the groups in the top 10, they were replaced by another bunch of people that followed afterwards. And so one of my conclusions that came out of this was that in the long run, if we're going to have a positive effect on frequent ED use, we've got to look at a bigger group. We've got to look at more patients and be able to manage that whole group rather than just the top 10. We've got to go farther down the list in terms of identifying plans for those patients. And there were other ones. There was an elderly patient with rectal CA who's coming in the emergency department for symptom treatment. And when I looked at his chart and investigated it, found that he hadn't seen his primary care in 6 months. He was trying to link up. The oncologist was just kind of going along, and they hadn't linked with palliative care, and palliative care hasn't seen him yet. So what I ended up doing was pull together palliative care and hospice with this patient and ultimately bring them to bear. Different guys with schizophrenia, behavioral issues, and who we determined he did not have capacity. He was not competent. And so the conclusion there is, let's quit beating around the bush and just get him into a placement setting and make sure that he's in a place where he can have that. Others, elderly dementia, remote family coming in with minor complaints to the ER, the end result again was, do we just place this guy? And on other patients, schizophrenia, transit homelessness, let's get him into the Mahicam program and have them take a look at them and manage them. So different recommendations came based on looking at each specific patient. And again, what we found was that idea that it was just the tip of the iceberg in terms of who we were looking at. And this is where I think one of the most important things that comes in is interoperable health records. That ability to look at the patient's medical record, primarily because these are complex patients. They've got a lot of stuff going on and a lot of comorbid conditions. They're utilizing healthcare resources. They got behavioral health issues. They got chemical in. And we really come to the conclusion that there's patients who are in need of care coordination. And that is ultimately what our goal is to provide that for patients. What is care coordination? Care coordination is the deliberate organization of patient care activities between two or more participants involved in a patient's care to facilitate the appropriate delivery of healthcare services. What is not care coordination is one ER provider taking a look at a patient in the ER and taking care of that problem. That's not care coordination. So what we ultimately look at is how can we involve the system and how can we make that work. And as we talked, it's a fraction of the patients. They have a lot of different issues, and really the key to addressing this from the papers and from the literature is the use of a care plan and the use of care coordination was what can ultimately address these reasons and lower their use. And you use different points of contact, whether it's an emergency physician, but I think one of the key pieces is that when you if you identify a patient in need of care coordination, each setting which that patient will find themselves in has to come up with a care plan for when that patient's in their setting. Because we're the specialists in emergency medicine, we should be the ones that define what the care plan is for when that patient comes to the ER. And it should be vetted with a primary care provider, meaning they should have a chance to see what our plan is. But that plan should be developed by us in terms of what we're going to do. And really, again, it brings together all of those components of the healthcare system. When we look at care coordination in the U.S., we find that it lags behind other nations in terms of what they're doing, and for all different kinds of reasons. Primary care providers don't have the test results or medical records. They're receiving conflicting information from different specialists or providers. They're ordering a test that the patients don't think is necessary. Specialists don't have the medical information when they see a patient. Their regular doctor's not up to date. They don't have the information that they need. So a lot of different issues that may be that reason. And the end result of lack of care coordination is you get a situation where 4 to 8% of the patients consume 24 to 28% of the resources. And we're hearing stories from the different patient populations that we're looking at, where a cadre of 100 patients or something like that will consume $7 million in terms of the resources that it's taking to manage that small group of patients. And again, the opioid use issue is one of the best ones, and one of the biggest things that ultimately addressed that issue was iStop, and the ability to have information on the prescriptions that were being filled by that patient, and us as emergency providers limiting the use of the opioids in the emergency department. If you ask me what my practice is now compared to what it was 5 years ago, or definitely 10 years ago, my use of opioids and controlled substances has decreased tremendously. And I think I'm still achieving the same outcomes. It's not like I've changed. It's not like the patients have changed a lot in terms of what they're doing. And we've developed alternatives for opioid use. We've come up with other reasons or other methods of how we can manage that patients. So as we're looking at it here with the development of our emergency telehealth and care coordination center, what are we going to do about it? What are some of the things that we can do that will try to help manage and care coordinate with these patients? What's in our toolbox? What are the initiatives we can use? And one of the key things is knowing who these people are. And that list here came from the People Inc. meeting. And what it was People Inc. going through all their patients that were getting a care and problems that came up and visits and things like that, and identifying the patients that were going to the emergency department. And from that list, we found, okay, here's the current fast risers on the People Inc. list, and this is who they're working with. And come up with those rates. Can we, ultimately, I would love to have a report from HealthyLink on who are the patients that we see and who's ranking as far as going to the emergency department or hospitalization most frequently. And look at that total burden of super frequent visits on the total patients that we're seeing. When are patients coming in and out of that list, and when do they go along for a while and then they do have a blip, and it's almost like once a SFIDU, always a SFIDU, where the behavior that created the super frequent ED use is always there, or the potential for it is always there, and all you need is a new trigger to have the patient have to come or end up coming to the emergency department. And cross-check, one of the nice things about the VA is I have all the data there, so I can cross-check the list of emergency department patients against the hospital admission list and the high-risk patients at the VA. The second thing is really a group awareness of the patient problem, and knowing that there's this group of patients out there that our goal is to try to manage. And it's interesting, when I started to work with this list and I started to go through the super frequent users, it was interesting that when they came, it was kind of strange, but when they came in the ER, I wanted to see them. You know, it's like I wanted to I'd done a lot of research on them. I'd looked them up. I knew who they were. And so when they came to the ER, it's like, I want to talk to you. You know, it's like, I want to know what makes you tick. You know, what are the things that you're going at? And sometimes it may be an opportunity for an intervention or trying to do something or find out what's going on with the patient. But it really changed my attitude toward who these patients were, and really try to also get an awareness by the primary care provider. The behavioral health group was great because they were part of our task group, and so we're at the table with the MAHICM director and the behavioral health. All of our behavioral health social workers were part at it, and identify who those special needs are. Who's on the homeless program? Somebody from there was part of our group too as we looked at it. The third piece is really use our electronic records and use our electronic chart review. And within the VA system, it was the local VA. We got VistaWeb, we got iStop, we got HealthyLink. Here it's going to be the People Inc. notes. It's going to be the facility record. It's going to be in the long-term care group, nursing homes. It's going to be their electronic health record. We're going to work on making sure that we have access to all of the electronic records that are available, so that when we take a look at a patient like this, we can find all the information that's out there. And just like you said, you've got to have access to that information, and you've got to have it as part of what you can do. One of the things that Tony and I are working on is ED, or the Emergency Department Information Exchange. And this concept came out of Washington State. And what it was it's a system of compiling all the electronic health records that are available into a report that's available and pushed to the emergency provider when they see a patient. And it's basically a 2-page summary, and it has all of the information in terms of their ED visits, their hospitalizations, their primary care providers, their medication list, their procedures that have done recently, their iStop search or something similar to that. And in talking to the people who work and have that kind of system, it was interesting because it removes the bias. You don't look for a certain patient as being the one who's doing the drug. You all of a sudden see, oh, this is a patient who's got an opioid use disorder, and this is somebody that we need to work with in that. And really, right now it's with HealthyLink. We're continuing that effort to have that, and I'll show you in HealthyLink where that report is and make it available. The one thing we found is we're trying to get it pushed to people, because once you go to the point of getting into HealthyLink to get to the report, now you're in HealthyLink, and so you can kind of cruise through all the other information that's there. But again, different patient scenarios. What's the MOL status, full code, limitations, comfort measures, do not transfer. When I was at the meeting this past Friday at Elderwood, one of the things that was very interesting is the kind of new guidelines coming down, which try to better detail, the levels between do not resuscitate, do not intubate, to comfort measures. The biggest bugaboo in the ER for those patients is IVs and antibiotics, and it's very difficult when families are trying to work through that to get them comfortable with withholding those interventions. And if you look at Canada, 40% of the patients in Canada who are on comfort measures get IVs and antibiotics. And so it's really something that you want to look at, because the overall goal is what's most important in terms of how you're managing that patient. Do they have inadequate housing? Home versus home assisted versus assisted living versus a SNF. What level are they at? And one of the things we found in our looking through patients was they're not at the right level of care. They need to be either moved from assisted living up to SNF. They need to be moved from home into assisted living. If we have a caretaker, let's get them in. So you really identify how can we change them to the appropriate level of housing and support that they need. Are there major psychiatric illnesses involved? And the concept that we found on the first patient we looked at, which is multiple hospitals, multiple ERs, what you get with that is fragmented care, and you don't get any kind of care coordination. So one of the things that I think is important in this process is how we go through and collect our data. And different tools that I used in this process, one of them was the idea of a spreadsheet. Develop a spreadsheet. So you develop a spreadsheet, which is, you identify the key pieces of information that you want to try to save on each patient. And I had ER visits within 60 days, but the other piece of data that we might want to know is how many days did this patient spend in the hospital in a 60-day period, and get some information like that. I would go through the VA records really nice that I can click down through their ED visits and look at their chief complaint coming in and basically list those chief complaints of what is it that got this patient to the ER. In the Healthy Link, you have the corollary of the listings of the emergency department visits and the complaint that's listed in that, and that might be a quick way to go through and identify why that patient's coming to the ER. But basically, you go through and identify different key data points that are going to be important in managing each patient, and part of the goal of the care coordination will be to build this data set and build this kind of piece of information on each patient, and then your care plan should build off of that spreadsheet. It should flow right from it, and ideally it's designed in such a way that filling in the information on the spreadsheet goes right to the report, so that you know what their problems are and what their things that they the issues that they may have in their management. So these are the ones we just mentioned, some of their medication issues, housing issues, family caregiver issues, and a summary or comment in terms of what we're doing with that patient. The fourth piece you look is, once you have the data, now you look at the idea to use evidence-based ER medical interventions and care plans, and develop and use different tools in your toolbox that you may have. So what is an emergency, and here I call it an emergency provider care plan, which may be more relevant to us because we're not an emergency department per se. But it's the idea that when we come across a patient, we're going to have a plan. It's a guide for a possible approach to the patients based on past patterns of emergency department utilization, and it can be implemented based on previous patient visits and standardized based or pre-written protocols. So you come up with different standard care plans that you would apply to patient, and certain patients may have 2 or 3 of those care plans added to them once you identify what the needs of that patient are. For example, one of the things that we came up with was identifying patients with diabetes, gastroparesis, frequent visits with abdominal pain, and opioid use. And what we found in those patients was that migraine and abdominal pain are the 2 things that I can look a patient in the eye and with all the confidence and medical confidence in the world say that the worst thing I can do for you is give you opioids. And I've got a paragraph about yay big and up to date that says that same thing. And so it's really evidence-based that opioids are not the best thing for you. So let's develop a protocol at the VA where we have IV Tylenol. Boy, I wish I could get that at ECMC. We've got Reglan, we've got Benadryl, we've got Zofran, we've got 2 liters of IV saline. So we've got a protocol that we can do that manages that patient who comes in. And it was interesting that the #1 patient, he was number 4 on my list of frequent ED users when I started looking at the VA, and we applied the gastroparesis protocol to him, and a month later he was on the fast risers at the ECMC. He was number 6 on the list of patients that were the fast risers at ECMC. So again, looking at it and changing people's behavior. Right now, unfortunately, we're kind of just moving them over to another facility. One of our migraine patients at the VA that we identified and intervened on, I went and was able to see that that patient was going to Mercy twice a week. And just, sometimes you change people's locations, but you don't change their behavior in terms of what you're doing. So what are the tools in the toolbox? The non-opioid pain management we talked about. Sometimes it's don't give a mouse a cookie. Make sure that you just don't reward a patient for being in the ER if there's nothing that they need to be in the ER about, because that's a behavior that's not supporting the other patients in the ER. We developed rapid diuresis protocols for patients with frequent visits for CHF. One patient we had was the ED care plan was call psychiatry whenever, call our behavioral health social worker when the patient comes, because we've identified in our group meeting that this patient is really at risk and needs to be brought into the system. And sometimes I've found that I step temporarily into the role of a primary care provider to make sure things get done in a short period of time that will have an impact on whether that patient will have to go to the ER or not. And I make sure that I vet those. I make sure in the VA system it's easy because I can make them an additional signer on every order that I do and every note that I write, so that they can see what I'm doing in that system. And like I said, I don't want to be there for very long. I don't want to be in that role. But sometimes it's important that I do it, because from their perspective, they've got 2,000 patients in their panel. This patient's not bothering them. They're coming to the ER. They're not even seeing them. And so that's, it's on us in a ways to try to intervene to get that patient back into their system. The other thing is, how do you use your system to alert other people that this patient's out there and has an ER care plan? And this is the challenge that we're going to work with within this system, is once you have a care plan, ideally when that patient comes up in your system, and MedEd can do this, where when we write a note in MedEd, we can flag it with kind of a use flag, like that an emergency department care plan exists on this patient that you should take a look at when you're deciding what you're going to do with this patient. And it's not really an alert, we found, because it is more similar to, it's something that everybody kind of thinks about and moves toward. It's just something that you have to look at with that patient and link them to that interdisciplinary care plan. So what's the electronic care plan implementation? It's implementing the care plan directly into the EMR. And I want to say Cerner is maybe the health record at Pittsburgh UPMC, and they have the care plans now developed into their electronic health record. And so that's the goal, is that those care plans are being managed, and they're right there when you're taking care of patients in the emergency department. And again, what should that care plan look like? There's one example that I circulated online that people could look at, which has a template for what this care plan should look like. And again, it should have demographic, basic, past history, current medical problems. I want that information to feed from something like a spreadsheet or something that is already there in the information, to try to make it more efficient. But it really gives, what standardized care plans should you apply to this patient, or are there other non-standard plans that you think are important for this patient? So I think one of the recommendations you had, is that you ultimately want to kind of take that recommendation and put it into an ED care plan, so that when that comes up, you can just check the box that says this patient needs that intervention. And you can apply that to this patient. We try to make sure that it's upgraded. Like I said, this is the whack-a-mole game. The patients are going like this. Once you're a SFIDU, always a SFIDU. So how do you do it in your system? But once it's there, it should always be there, but put in the context of what the patient's doing right then, and whether you've ultimately had success in terms of how you've managed that patient. And I mentioned the vetting also by the primary care provider, by the other people that are involved in that patient's care. And I think in MedEd that may be something that we can do if there are a patient. Another piece in our toolbox is that appropriate level of housing that we talked about. Do they need assisted living or a higher level of care in that? What's their housing arrangement if the VA is supporting that? And again, are they using their financial resources that they get for housing like they should, or are they using it for cocaine or something else? So, make sure that everything's going to that. And again, the different levels that we found, and I think there's different names in here, but there's like 2 levels in the domiciliary, which is a group home or transitional living, all the way up to assisted living, and finally to skilled nursing, and within that to a memory unit. So where do the patients stand on that continuum of different housing situations? Other items in your SFIDU toolbox. Sometimes you just got to confront somebody and say, the behavior that you're doing here is not is so far out of whack from what we normally see in emergency department patients. What's going on here? You know, why are you coming in here every other day? You know, is that, you know, because that's really not what we normally see in patients in the emergency department, and can we change that behavior? The assignment of a fiduciary may be part of that. Home-based primary care we talked about as can be a great intervention. Should they be on telehealth? Should they have the daily monitoring of their weights, their pulse ox, their you know, vital signs? Is that something? From a behavioral health standpoint, should they have some more constant and frequent interaction with that? And finally, in HealthyLink, and we found through our research with HealthyLink that almost 5% of the patients in HealthyLink are refusing consent, and of those, a significant number of those are the frequent ED users, and not allowing an emergency physician who doesn't know them the ability to see their records so they can provide the best care in the emergency department. So what are the next steps in this? It's continue to review these top 10 lists, emphasize the rapid risers, but just go through those, and as we go through them, think about our process. What's the best process for this, and what changes need to be made in it? How can we better keep this information and pass it on to the next person that works with them? And really identify and present patients with those known scenarios. Develop our alerting system within the electronic health record so that we can see it when one of these patients come. And finally, data analysis to identify patients. Well, if I identified a patient with abdominal pain, gastroparesis, opioid use, and frequent ED use, why can't I do a study that basically looks for all those patients that we're seeing with those scenarios? Why can't I look for patients with advanced stage cancer and see if they're coming into the emergency department for their treatment and need palliative care or need advanced illness work? What are the patients who are primary care challenged and haven't seen their primary in the last 6 months but are coming to the ER frequently? Can I look for those patients using data mining? You know, which are the patients with CHF, COPD, schizophrenia, polysub? So the next step is be more active in taking a look and finding these patients that are in that iceberg of frequent ED use. And that, in a nutshell, is care coordination, or at least the start of it, because it's going to be a journey in terms of where we go with this process. And as we mentioned, I think the biggest thing is the feedback. It's finding out, you know, okay, how would I go about it? Can we do this? Is this something that we can look at? Is that too cumbersome? Can we do this? Can this interact with this so I only have to put it in once and it'll show up on my ED care plan? What are the ways that we can make this system more efficient? Any questions? John, thank you.
You're welcome.